Well, good morning or good afternoon or good night, everyone, depending on where are you connecting. This is an international meeting. We appreciate you are joining us today for this mini online seminar series that this is an educational partnership between the ISN and GLOMCOM. This is our seminar number 4, and we'll be reviewing the renal involvement in lymphoproliferative diseases.
Good morning, good afternoon, good evening, and good night to all our colleagues around the globe. And I would like to thank the ISN programs, GLOMCON, and the ISN Path Committee, which Dr. Avila has just mentioned, for giving this opportunity to share some of what we have seen. This particular subject is off the beaten path, but nevertheless, we do see these cases from time to time where cases are known who come with monoclonal gammopathies or with lymphomas ahead of time. But at other times, it is the renal pathologist or the nephrologist who are suspecting and confirming these diagnoses and for what renal involvement has taken place. Having said that, a brief outline of this talk. This is a very ambitious talk, and I hope it will be useful to you. And so after the introduction, mention briefly about the kidney involvement, the extent of it, and very briefly our experience over the years in terms of the numbers. And I will then show you the bulk of the talk will be 5 cases to illustrate the scope of renal involvement and the type of diseases that we will see. I will also briefly mention some additional examples of other renal entities that go along with these with this subject, and of course the summary and conclusions. So hemopoietic malignancies comprise all forms of myeloproliferative disorders, lymphoproliferative and plasma cell disorders. In both children and adults, it is not a purview of only adults. It spans some of the acute leukemias and Burkitt's lymphoma and others. They also occur in children, which can affect the kidneys. Almost now, we will restrict ourselves today to mainly lymphoproliferative disorders. Almost all forms of these malignancies, Hodgkin's and not Hodgkin's, both in immunocompetent and immunodeficient settings, age-related lymphomas, lymphoproliferative disorders, viral-induced lymphoproliferative disorders, and post-immunosuppression related immunodisorders. All of these can be associated with renal disease, and thankfully, the incidence is fairly lower than all the other medical kidney diseases that we see. So the extent of involvement, the kidneys can be involved by direct infiltration, or they can involve specific compartments of the kidney, particularly monoclonal proteins, and sometimes infiltration by the lymphoma cells as well. Glomerular lesions secondary to cytokines or circulating soluble factors, podocytopathies, and other paraneoplastic effects such as amyloidosis, acid-base balance, which we will not deal with today. And this is what I would like to also mention, which is that this renal disease may be the initial manifestation of an underlying lymphoma or leukemia. And we may be the first one alerting the clinician or even the hematologist that this patient may be harboring one of these conditions. Or the kidney may be the location of a primary lymphoma, which may be diagnosed by a biopsy or by a nephrectomy specimen. So treatment of the underlying lymphoma in most cases has paralleled partial or complete recovery of renal disease in most cases, unless some of the damage that has occurred in the glomeruli or within the parenchyma is irreversible at the time. And we have also seen the reappearance of the renal disease when there is heralding a recurrence of the underlying lymphoma. And one of the cases that we had, mantle cell lymphoma, had a podocytopathy with nephrotic syndrome. They treated the lymphoma and the patient got better. The nephrotic syndrome went away. And 2 years later, 2.5 years later, the nephrotic syndrome